Hello, friends. I'm proud to give a shout out to our sponsor, the Canadian Legacy Project. Veterans Affairs Canada is very limited in its service offering to veterans, so the Canadian Legacy Project has stepped up to fill the gap. CLP develops and delivers a full suite of free programs for Canadian veterans. CLP celebrates our veterans by offering meaningful support for healing and the transition to civilian life. Homes for Heroes, Business Boot Camp, service dogs, educational bursaries, equine therapy, and more are available through the Canadian Legacy Project. Find out more at canadianlegacy.org. Hello, all you beautiful souls. Thank you for joining me for another very important edition of Operation Tango Romeo, the trauma recovery podcast for veterans, first responders, and their families. On the show, I have talked about Quinism more than once. We've had my buddy Mike Rood on here, Dave Bona, and others to talk about Mefloquine poisoning and what that is. But what I've never had on the show is a professional opinion. It's always been from the people that have been affected by it, trying to describe what the symptoms are like. And I've been chasing that rabbit for a while now. So I'm really happy to have Dr. Remington Nevin on the show, an actual doctor who has been involved with Quinism for some time. And he's a U.S. Army vet as well. Remington, thank you.
Yeah. Hi, Mark. Great to be with you.
So let's talk about your service. It says on your LinkedIn profile, which looks like you don't use very much, that, but it's there. So tell me about your time in the U.S. Army.
Yeah, thanks. So as you may be able to tell, I have a little bit of a Canadian accent. I was actually born in Toronto, Canada. I was a dual citizen from birth, but I knew I was going to live in the States as an adult. So after college, I joined the U.S. Army. They have a pretty good deal. They have a medical school that's run by the military, and they pay for your medical school. They also let you serve on active duty as an officer while you're going to school. So I was getting full pay and benefits while I was going to medical school in the U.S. Army. And I knew early on that I was going to do public health and preventive medicine. So I went into that specialty after graduation. I was fortunate enough to get to go to airborne school, my final year of medical school. And not surprisingly, someone that's gone to airborne school as a doctor, you end up at Fort Bragg down in North Carolina. So I did my family practice internship there, ended up going back to the DC area to do residency in public health and preventive medicine. The U.S. military paid for a year at Johns Hopkins, what's considered one of the world's best public health schools, went to the Walter Reed Army Institute of Research for my residency. And that started my career as a public health physician in the U.S. Military. I was initially stationed out of the D.C. area, but soon enough, I was actually selected by my old residency supervisor, who was then the surgeon of the 82nd Airborne Division, to join him and the 82nd Headquarters Company on an all expenses paid trip to Bagram, Afghanistan. And that was, I think, in 2007. And I got to serve alongside several Canadians. I was down there at Kandahar. I actually won a free coffee at the Tim Hortons there, if you can believe it. But it was there in Kandahar and Bagram that I saw firsthand the effects of Mefloquine. We had prescribed this to all of our folks, and I would say within a few months, I was noticing some pretty significant changes in behavior in folks in my unit, in folks that had been outside the wire. And this is what started my subsequent research interest in this topic.
So one of the challenges when I've had this conversation is the DSM lines up diagnostic statistical manual, the symptoms for line up for all brain injuries, whether it's post-traumatic stress injury, a concussion, a TBI, blast injury, CTE, or Mefloquine poisoning. It just lines up the same. From memory issues, it's all seems to be in some sort of an encephalitis. So how do you parse it out? How do you know it's quinism and not a combination of complex PTSD and concussion?
Yeah, well, you raise a good point, and if this weren't the case, if it weren't the case that the symptoms caused by chronic mefloquine encephalopathy, or what we call quinism today, if it weren't the case that those symptoms weren't very similar to those caused by other conditions that are prevalent among combat veterans, PTSD, traumatic brain injury, there would already be much more recognition of this. It's precisely because the symptoms so closely mimic those of other more established diagnoses that it's taken so long to recognize this. Now, in medicine, there are various ways to formulate the differential diagnosis. You can run lab tests, you can order imaging scans, you can do a physical examination, you can do special provocative tests to see what the results of those are. But all medicine and all diagnosis ultimately begins with what's called a history. You talk to the patient and you ask them what's going on. How did your symptoms begin? How did they evolve? When did you first notice them? And what I found is that with very few exceptions, it's almost always possible to reliably attribute these effects to mefloquine, even in the presence of other potentially confounding diagnoses, such as post-traumatic stress disorder and traumatic brain injury. And the way
How
you
can you?
do this,
Okay, I'm sorry.
yeah,
I jumped ahead of you.
that's all right. The way you do this is you simply talk to the veteran. So, for example, post traumatic stress disorder is a condition marked by symptoms such as nightmares, anxiety, paranoia, depression, perhaps some cognitive problems, right? We all know post traumatic stress disorder, but it's post traumatic stress disorder. It's not pre traumatic stress disorder. You can't develop post traumatic stress disorder before you experience a trauma. And so, for example, a veteran who deployed overseas and definitely saw some bad combat, but who reports having begun mefloquine prior to starting deployment, as was typically done, right? You take one or two pills in the weeks before deployment. If that veteran, for example, describes the onset of vivid, horrifying nightmares in the days to weeks before they deploy, before they ever saw combat, and it's those particular dreams, whatever the theme might be, right? Perhaps they're having nightmares of monsters or snakes, or perhaps they're having nightmares of them doing terrible things. You know, they are the monster. If it's those dreams and nightmares that continue even after the onset of trauma, then how does it make sense to attribute those dreams to the combat trauma? And likewise, symptoms such as paranoia or anxiety or depression or some cognitive problems, if a history clearly reveals that these symptoms began prior to any plausible trauma, it makes little sense to attribute their persistence to the subsequent combat trauma and not to the taking of mefloquine, because we know that folks that go overseas, even on a relaxing vacation, and who take mefloquine for the prevention of malaria, like deployed soldiers do, they can develop these same chronic problems in the complete absence of any plausible trauma. I tell veterans, you know, the real question is, if instead of being deployed to Afghanistan, if you were given this pill and you had developed all the same early symptoms that you report, the nightmares, the anxiety, the paranoia, and your mission, instead of going to Afghanistan, was to deploy to a beach in Mombasa, Kenya, and sit and drink Mai Tais for 2 weeks, would you have still experienced all the same symptoms that you complain of? And many veterans will report, well, yes, actually, I would have, because many folks that go on vacation and take this drug as civilians come back reporting having had just as horrific an experience from the nightmares and from the other effects of the drug as many soldiers report.
Let's talk about these dreams and try to parse that out a little
Yeah.
bit. I've had them described to me by people that have been poisoned by mefloquine as so vivid
Mhm.
and so over the top, like not like any other nightmare.
Yeah.
Like to call it a nightmare is almost a euphemism. By the way, it's been described to me.
Yeah.
People that say that they have had waking nightmares
Mhm.
where they are fully conscious but the line between dream and reality is just not there at times.
Yeah.
So they can't even tell what's going on. So how would you paint the picture a little bit sharper to describe the severity of these nightmares, and would you even call them nightmares? And what's the mechanism of injury? Like, what is it about the Mefloquine? What is it actually physically doing that presses
Yeah.
the magic button for a hellscape in these nightmares?
Yeah, it is a rather remarkable effect. I have often described mefloquine as a psychotropic drug, meaning a drug that has effects on the brain, that primarily has psychotropic effects, and that only incidentally has anti-malarial properties. And the reason is that if you are among the miserable minority that suffer these effects from mefloquine, many people won't experience even nightmares from mefloquine. We think perhaps a large minority or a small majority are susceptible to these effects at the typical dose of 1 tablet a week. But if you are among the miserable minority that suffer these effects, you'll typically experience these symptoms, these prodromal symptoms, within the first few tablets. So after 1 or 2, 3, maybe at most 4 tablets, you'll know if you're susceptible. And among the earliest prodromal symptoms are these vivid, hyper-realistic dreams. Now, whether the dreams take on a positive or a negative valence, whether they are pleasant or whether they are disturbing, it does seem to vary with the individual. And I can't think of a particular reason why some people experience nightmares and other people experience very pleasant dreams. I can tell you, Mark, from my experience when I was in Afghanistan, I had very vivid, pleasant dreams. I was a rock star in my dreams, and I enjoyed going to bed because it was the most interesting thing that I experienced in boring Bagram. I would be sitting there doing PowerPoint slides as a staff officer 6 days a week, 12 hours a day. And my dreams were the only interesting thing I experienced. Many veterans will report this, merely vivid dreams and not nightmares. But other veterans will describe their dreams as deeply, deeply unpleasant and disturbing. And as you described, hyper-realistic. Early on in the drug's use, they were described as technicolor, hyper-realistic dreams that bled into the waking hours. And so people would wake up and they wouldn't be able to really determine whether they were still dreaming or whether they were fully awake. Now, the reason for this is broadly because in susceptible individuals, the drug is poisoning the brain. It's causing encephalopathy. It's having encephalopathic effects on that part of the brain that controls dreaming and sleep. And this part of the brain.
Let's just translate encephalopathy.
Yeah.
Is that simply inflammation?
So encephalitis is the term for an inflammation of the brain that can produce similar symptoms to an encephalopathy. So there's a condition that mimics mefloquine encephalopathy somewhat. You may be familiar with this term, limbic encephalitis. It's an inflammation that can be due to autoimmunity. Some people with certain cancers develop autoantibodies, and they experience very similar effects, vivid dreams, anxiety, paranoia, psychotic-like effects. This is all broadly due to physiological dysfunction in a particular part of the central nervous system. If you look at a brain, you have the big part up here, right, the cortex, which is responsible for many higher level functions, complex thoughts, and so on. And then you have the brainstem. And the brainstem is evolutionarily a much more ancient part of the brain. And the brainstem and the surrounding limbic system are the ancient parts of the brain that are responsible not for higher thought and cognition and composing music and writing poetry and being an architect and doing all sorts of things that we associate with human knowledge. The limbic system and the brainstem are responsible for the core features of mammalian life: fight, flight, basic survival, sleeping, dreaming, core memories. The amygdala, which is often associated with the pathology in post-traumatic stress disorder, is responsible for fear memories, right? That's part of the limbic system. The hippocampus, which helps to set in memories long-term as we dream, that's part of the limbic system. And then the brainstem, things like the reticular activating system, neurological structures that allow us to dream that we're moving our bodies without our whole bodies moving. All of this area, the limbic system and the brainstem, are what we think are primarily affected by the encephalopathy caused by mefloquine. For whatever reason, mefloquine seems to penetrate into those areas at perhaps higher concentrations than in the cortex. And perhaps for whatever reason, those areas seem to be more sensitive to the encephalopathic or poisoning effects of this drug. So that is what's responsible for the vivid dreaming. It's what it is it's a warning sign. It's a prodromal symptom or a precursor symptom warning you that your brain is susceptible to the effects of this drug, that your brain is potentially being damaged by this drug, and that you should stop the drug immediately. That's what those dreams should be interpreted by soldiers as. But unfortunately, as we know, for years, soldiers were told, look, take this drug. You may have some crazy dreams. You'll be fine. And that was actually malpractice. We should have been warning our troops all along that if you experience the vivid dreams, the nightmares, any sort of early emotional symptom, anxiety, depression, paranoia, sense of unease, that was a warning sign that your particular brain, for whatever reason, was susceptible to the effects of this drug, and you should stop the drug immediately.
Is there a family of drugs that are in the quin family? Because there's also hydroxychloroquine.
Yeah.
Are those all in the same family of drugs?
Yeah, that's right. So mefloquine is what's called a quinoline drug, and in fact, mefloquine is just the latest in a long series of synthetic quinoline drugs that have been developed mostly by the U.S. military since the World War II era. The prototypical drug of the quinoline class, the prototypical anti-malarial drug, is actually the naturally occurring drug quinine, which is found in the bark of the cinchona tree. This was discovered by Spanish explorers in South America, I believe in the 16th century. The fever tree was noted to have these fairly miraculous properties, and that it could cure or at least prevent malaria. And it was the extract of the bark of the cinchona tree, quinine, which was only chemically isolated many hundreds of years later, but which was recognized for its medicinal effects by various colonial powers. It's what permitted military expansion throughout the world. So the British Empire, you may be familiar, they popularized the drinking of gin and tonics, right, by their colonial forces. When they were in India or they were in Africa, it became customary for British troops on colonial duty to drink 2 or 3 or maybe more gin and tonics. And the tonic water contained fairly large amounts of quinine. And so it just happens to have been the case that by drinking 2 or 3 tonic waters a day, maybe more, and the gin would obviously make it more palatable, and the sugar in the tonic water.
Is that why they taste so terrible? Is that the quinine?
Well, so some people claim to enjoy the taste of tonic water. I think
nobody that's sane.
Yeah, I think the gin and tonics became a cultural thing. It became culturally normative because it was necessary for the health of British colonial forces over the years. But the taking of 2 or 3 gin and tonics a day gave you enough quinine in your bloodstream to keep any malaria infection that you may have had at bay. And so it really did permit colonial expansion all around the world. You know, the Romans never colonized sub-Saharan Africa because if they had tried, they would have died from malaria. But the British were able to colonize Africa. They were able to colonize India and elsewhere that were endemic for malaria because of the magic of quinine. Now, quinine was a perfectly good anti-malarial for military missions. So in the 19th century, wherever the British would go, quinine served its purpose, preventing malaria. But after World War I, where quinine was used, of course, with the way world power evolved, the Germans ended up essentially having a lock on all of the world's quinine plantations. So most of the quinine at that point was grown in Indonesia. And in the years leading up to World War II, the Germans essentially had a lock on that area. So they could essentially quarantine the world's supplies of quinine. And so what would become the Allied forces, the British and the Americans and others, began to explore synthetic alternatives to quinine. And one of the drugs that they explored was a drug called atabrine or quinacrine. And in the years leading up to World War II, the U.S. actually knew that war in the Pacific was coming. They were very concerned that there wouldn't be enough quinine, that the U.S. stocks would be depleted. And so they embarked on a two-pronged effort. The first was to obtain sufficient quantities of quinacrine or atabrine for the war. And the second part of this two-pronged effort was to engage in a massive scientific discovery effort looking for improved alternatives to atabrine. And it was this massive drug discovery effort conducted by the U.S. government, the U.S. military during World War II that led to many of the drugs you mentioned. So chloroquine emerged from this effort. It had actually been synthesized by the British or by the Germans, but we rediscovered it during this process. Hydroxychloroquine emerged from that shortly after the war, and a drug called primaquine, which is still used today, also emerged from that effort. Now, you may be asking, well, why did they bother to synthesize chloroquine and hydroxychloroquine and primaquine if they had atabrine? And the reason, Mark, is that the U.S. government, the U.S. military knew that atabrine or quinacrine, which is technically a quinoline, had a very significant problem. And that problem is that it made soldiers go crazy. They knew this, but they couldn't reveal this fact to the soldiers for obvious reasons, because we were about to embark on a vicious, months-long, years-long campaign of often hand-to-hand combat in the jungles of some of the most malaria endemic areas in the world, the islands of the South Pacific, which were endemic for malaria. And the U.S. military knew that if soldiers were not taking their anti-malarial, that we would essentially lose the war in the South Pacific, that we would lose more men to the effects of malaria than to Japanese combat. And so the military actually classified information on the adverse effects of atabrine as confidential or secret information. You could not publish as a doctor. You could not mention publicly that these drugs had these adverse effects. And what were the adverse effects of atabrine? This is going to sound very familiar. Vivid nightmares, insomnia, anxiety, depression, confusion, restlessness, paranoia, and in extreme cases, psychosis. The exact same symptom profile that veterans today recognize very clearly as being associated with Mefloquine were well known during World War II by folks with knowledge to be associated with use of quinacrine. But this information was not allowed to be published, Mark, until after the war. And after World War,
are there any members with are any of the drugs within the quin family safe?
Well, safe, defining safe is relative, right? So there are applications where the benefits of the drugs exceed the risks, and so by traditional drug safety terminology, you would consider those safe for the indication. Now, I think there has long been if let's put it this way, Mark, if you're in the jungle and you're going to die unless you get an anti-malarial, and the only drug that you have is a quinoline anti-malarial drug, and again, if you don't take it, you're going to die of malaria, then of course the benefits exceed the risks, right? And so in that case, you would consider the drug reasonably safe for the indication. But for prophylaxis, for prevention of malaria, which is the indication that I'm describing, after World War II, there typically were safer alternatives. Now, during World War II, it is a valid question whether the military had any choice, whether they really didn't have a choice but to lie to the soldiers, mislead them about the safety of this drug, and prescribe them a drug that they knew would make ill maybe 1 or 2% of the population that they gave it to. Why? Because if they didn't, the United States would be facing an existential threat in Japan. We might be speaking Japanese in California if we didn't win the war in the South Pacific. So for the military planners of that era, in their mind, it was probably appropriate to take that risk. And there really wasn't an effective alternative. Quinine was better tolerated, but we didn't have access to reliable supplies of quinine. And by that point, we hadn't recognized that there were other classes of drug that had as effective antimalarial properties as we recognize today. So are there safe quinolines for prophylaxis of malaria? I would say probably not. Some can be used long-term in people who tolerate them. because not everyone seems to be sensitive to these drugs. But
in the hierarchy of safety, is there one that's better than Mefloquine? Like, was hydroxychloroquine a better
right,
option that
yeah.
just wasn't used?
Well, now hydroxychloroquine it hadn't been synthesized in the World War II era, and chloroquine was only being
I'm
discovered.
talking Afghanistan, though.
Yeah, well,
Afghanistan and actually Somalia. So
yeah, right.
the
So, more
Quinism
recently,
that
yeah,
started in for Canadian troops
yeah.
was right around 91, 92,
That's right. Yeah,
or
in the
93,
fall and
94.
winter of '92. So by that time, Mark. So by the '80s and '90s, there actually wasn't a good reason for any military to be using any of the quinolines as a primary anti-malarial drug, because by this point we had actually discovered that there were safe and well tolerated antibiotics that served the same purpose. So, for example, by the time of the Somalia campaign, the U.S. military had been using a common antibiotic known as doxycycline, which is commonly prescribed to adolescents with acne and to various folks. If you have one or more STDs, you may get prescribed doxycycline. Very commonly used in the military, as you can imagine, for those two indications and others. And it reliably prevents malaria. Some people think it has some disadvantages relative to mefloquine because you have to take it every day, but that's just good discipline, right? So if you take your doxycycline every day, it is a very effective anti-malarial. And in fact, much of the U.S. military used doxycycline during the Somalia campaign. And
Has doxycycline been shown to, in many cases, cause really severe depression and suicide?
so for whatever reason, Mark, all anti-malarials, if a drug is effective against malaria, for whatever reason, probably because the drug has to penetrate lipid membranes. So in order for a drug to be effective against malaria, it has to get through membranes that are normally closed to many drugs. And it's that property that does create some risk of central nervous system effects. So
So,
all anti-malarials,
including the blood-brain barrier, then.
yeah, that's right. So it's not a universal effect, but it does seem to be that if a drug can work against malaria, then it does carry some central nervous system risk. But the risks are so much greater with mefloquine and other quinolines than they are with any other class of anti-malarial drug. And unlike mefloquine, doxycycline and the safer drugs, atovaquone and proguanil, these haven't been shown to be encephalopathic or neurotoxic. And the quinolines, they appear to be unique among available antimalarials in actually having encephalopathic and potentially permanent neurotoxic effects. And that generally renders a decision to use these drugs very risky and generally not worth the benefits. For many decades.
Is there any risk for drinking a liter of tonic water a day?
Well, yes, in fact, and this has been a longstanding goal of mine and the organization that I run. In due course, perhaps when we have a little more time, I would like the FDA to reexamine its approval of quinine, because if you do drink enough gin and tonics, and many people, I recall when I lived in Baltimore, and I would go out to the clubs and so on. I do recall I counted the number of gin and tonics a friend of mine drank, and I did the math, and I realized if they're doing this every day, as they were, they're exposing themselves to a very unsafe level of quinine, and so I do think the FDA should reconsider the safety of quinine in tonic water, and perhaps consider eliminating it altogether. There are many other awful tasting bitterants that they could add to tonic water in place of quinine. If you want a disgusting tasting drink, there are any number of options to add to your gin if you want that. But I digress. Quinolines, they definitely serve the purpose, Mark. So obviously in the era of tonic water and quinine as a military antimalarial, there was no choice. The British Empire as it existed, and what is left of it today simply would not have existed if it weren't for quinine. The British
with a twist
Empire,
of lime, of course,
with or whatever it is that you want to add to it. Western history owes much of its development to quinine being an effective antimalarial, and through World War II, the use of these very dangerous alternatives, I think, was probably essential. if we were going to fight and win World War II in the South Pacific, we needed something like Ativan. And maybe during Korea, we also needed it because we didn't have any effective alternatives. And possibly even into Vietnam, we didn't understand that there were other alternatives. But I would say by mid-Vietnam, by the end of the Vietnam era, we had alternative drugs, and we really did not need to use quinolines anymore. So I would think any military use of the quinolines after the Vietnam era was probably unjustified and probably unwise. And I think it has almost certainly contributed to a missed epidemic of neurologic and psychiatric disease. And we could talk about the evolution of awareness of mental illness associated with combat, and how much of that has probably been confounded
What are
by
some of
the.
the other? I'd like to get into,
Yeah.
if I could. We've talked about the nightmares that basically caused from, let's call it brain damage,
Yeah.
just to keep it simple. The brain damage caused by the quinism. What are some of the more unusual and less known symptoms? Maybe physiological symptoms.
Yeah.
Is there IBS?
Well, that's a good question, and we have more questions than we do answers. So
Hmm.
at a physiological or cellular level, how mefloquine is acting is as a neurotoxicant. So in some people, for whatever reason, it appears that mefloquine can penetrate the blood-brain barrier, and so access cells in the brainstem, the limbic system, and theoretically the cortex, prefrontal cortex, where executive functioning resides, and penetrate into the individual cells in those areas, and at a high enough concentration, which varies with the individual, but certainly will increase over time as you take more and more mefloquine in the presence of these symptoms. The drug can not only cause physiological dysfunction of these neuronal cells, but in extreme cases can lead to their death. And so even going back to World War II, during this drug development effort that the U.S. military, the U.S. government had sponsored, we knew that various quinolines related to mefloquine were causing what was described at the time as remarkable neuronal injury, meaning if you gave these drugs to experimental animals like dogs or monkeys, and then you euthanize the dogs or the monkeys, and then you chop their brainstems up into little thin slices, and you stain them and you put them under the microscope, you would see microscopic damage under the microscope. You'd see individual cells in brainstem nuclei and in other structures of the limbic system. In some cases, massive dropout of cells. Now, this type of microscopic injury would typically not be visible even with modern imaging. So if you would have run these dogs or monkeys through an MRI, if we had them at the time, you probably wouldn't have seen any damage because the damage is cell specific and it's microscopic. You may have one neuron die and adjacent neurons are completely fine. That's not going to show up on MRI. There may be a little bit of swelling. There may be a little bit of
I'm sorry, just to steer you a little bit though. But as far as the effect on the quality of life for the person, how does that translate to unusual symptoms that we may not be aware of?
Yeah, well, so let me get to that. So if once you start to have neuronal dropout and neurotoxicity, two structures in the brainstem and limbic system, Mark, then really all bets are off, because the brainstem and the limbic system are responsible for our core physiological functions. So I mentioned the reticular activating system and control of sleep. So you can imagine that if structures in the brainstem responsible for control of sleep are damaged, then an individual may quite literally never have a good night's sleep ever again in their life. And if they do get to sleep, they might suffer continued nightmares, which are otherwise impossible to prevent. Chronic psychiatric symptoms, such as nightmares, vivid dreams, insomnia and other sleep disturbances, restlessness, and then anxiety, depression, confusion, intermittent psychotic episodes, the cause of which we're unclear of, but might possibly be related to some sort of decreased seizure threshold. There's something you may be aware of called temporal lobe seizures. These are very odd seizures where the person appears to be conscious. They're not flailing around on the ground, but they're actually experiencing mild psychotic breaks intermittently, often associated with very violent thoughts
I've
and
seen them.
occasionally actions. Yeah, so those are probably comparable to temporal lobe seizures, which may be an effect of the brain damage caused by mefloquine triggering a seizure in those emotional areas. Now, as we move down the brainstem, you get to areas of the brainstem that control your vestibulo-ocular reflex. And what do I mean by this? Well, as an example, and you can do this test yourself. If you hold up your finger in front of your eyes and you move your finger back and forth like this, you'll notice you can't keep focus on the tip of your finger because your eyes have to track visually, right? Your brain has to figure out where the finger is and engage in some complex thought to move your eyes to where the finger is. Now, that being said, if you hold your finger steady, and I have to make sure I'm holding up the right finger. There we go. So if you hold your finger steady and you move your head back and forth, and you can try this yourself as you're watching this video, if your vestibulo-ocular reflex is functioning correctly, if your brainstem and eyes are working together correctly, you'll notice you maintain perfect focus. So this you can focus, this you can't focus. This requires extraordinary coordination between areas of the brainstem that are often damaged in mefloquine veterans, the vestibular nuclei and the various ocular nuclei. And so many mefloquine veterans will not only complain of things like anxiety, but they'll also complain of intermittent dizziness, vertigo, a sense of spinning. And Mark, here's the most interesting thing, a sense of discomfort in areas or situations that stress the vestibular system. So grocery stores, and sometimes driving through tunnels, driving over bridges where there's flashing, where it's difficult to establish a visual horizon. There's an old concept in psychiatry called agoraphobia. You may be familiar with this term. Many veterans with PTSD are told they're agoraphobic. They're afraid of going out of their house. They're afraid of going into certain situations. Agoraphobia literally means fear of the marketplace, fear of the grocery store.
Oh,
And many veterans will describe a sense of unease or panic or an unwillingness to go places like grocery stores, where there are long aisles, where there's flickering fluorescent lights. Now, the psychiatrists will explain this by saying, well, you're afraid of there being, some sort of event in the grocery store and you're not able to be safe. And that's why you're afraid to go to the grocery store. But there's another possible explanation for this, and that is merely that going out of your house and going to places like grocery stores and driving exposes you to these vestibularly challenging environments where your sense of vertigo and your like a sense of fear of heights can be triggered artificially. You know that feeling, Mark, when you come across a cliff suddenly, or maybe you're watching a video and you're watching someone walking over the tops of buildings, and many people feel afraid. Simply watching that video, and certainly if you come across a cliff, many people will fear that environment. Imagine feeling that way. Imagine feeling anxious or afraid or even almost panicky in completely benign settings while shopping for Fruit Loops at the grocery store. This is what many mefloquine veterans experience, and it could very well be not because of a psychiatric effect, but because of a neurologic dysfunction in their vestibular nuclei and their vestibulo-ocular reflex.
this
So
is a
that's
really good example of how there is it is difficult to parse out hypervigilance due to a post-traumatic stress injury
yeah,
and mefloquine poisoning.
yeah,
If you're, because all the things that you're describing also are part of hypervigilance, where
yeah,
you're just in the way I describe it, the simplest way that I've found to describe it is sometimes your throttle gets stuck on full.
hmm
And when you have enough high level events for first responders, it's more of a drip, drip, drip. But at the end of the day, the injury is throttle being stuck on full. So fight, flight, freeze, fawn, one of those all the time. And if you're a
yeah,
combat veteran, flight, freeze, or fawn don't work. It's
right,
only fight. If you have a
yeah,
problem, kill it. So you are constantly in, if I have a problem, kill it mode. And if there are more targets of opportunity, more potential mechanisms of threat, because you're in a crowd, so there's more people, so there's more data to parse through. that is simply overwhelming, because you're doing threat assessments on every living creature
Right.
that's there, every window, every person, and you're doing an incredible amount of math and analysis, uh, points of egress, you name it.
Yeah.
And that is the cause of the anxiety, because your brain is just trying to process way too much information.
Yeah.
Whereas if you're in a combat zone, it's much more simple. It's like
Yeah.
there's bad guys, probably half a dozen of them. So I got half a dozen people and maybe another half a dozen windows that I got to worry about,
Yeah.
and that's it.
Yeah. Yeah, that's right. It's said that most of your brain power is actually devoted to stopping you from doing things rather than doing things. So your prefrontal cortex is usually the part of your brain telling you, don't do that, right?
Yeah,
So if
like throat trapping people that annoy you.
yeah,
That's
that's
definitely
that's
takes
right.
up about 80% of my brain.
Yeah, well, and I do think the prefrontal cortex, of all the cortical areas, I do think the prefrontal cortex and the areas connecting that to the limbic system are also damaged by mefloquine. So you do have a reduced threshold for action. I think mefloquine does leave many veterans with a reduced threshold for violent action, for acting on common violent thoughts that we all experience at one point or another, and then coupled with this lowered seizure threshold that in some people can lead to these episodes. And many Mefloquine veterans, or many veterans, will be aware of these episodes in their fellow buddies. Their buddies will seem to just sort of tune out for a few minutes, and they'll be off in space somewhere. And they may be experiencing a transient, mild psychotic break where they're wrestling with hallucinations and all sorts of deep, dark thoughts. And hopefully they'll get out of it, without any bad things happening. But Mark, I want you to picture the net effect of this. So imagine if you're a healthy veteran, healthy service member, you have no problems at all, and then you take mefloquine, and within a couple weeks, you're having very disturbing dreams, not of monsters or snakes, but of you being the monster, of you, the veteran, doing terrible, awful things to family members, right? And I won't get into the details, but many veterans have privately confided in me that they'll tell their doctor they're having nightmares of combat and mortar explosions and things, but what they're really having nightmares of is themselves being demonic and doing just awful, unimaginable things to family members. Now, you go overseas and you see a bunch of bad stuff, and you come back and you're paranoid. You think you're a bad person. You think you're dangerous because of these awful dreams that you're having. You can't function in society anymore. You're a nervous wreck. You're afraid to go to sleep because of the nightmares. And so to numb yourself from the nightmares and stop yourself from having the nightmares, you drink yourself silly every night, because the one treatment that does seem to stop the nightmares is alcohol. If you drink a 6-pack or a 12-pack of beer at night, you're probably not going to remember these awful nightmares you have, right? And then you notice that you are, well, besides having become an alcoholic as a result, you notice that you simply can't control your emotions as well as you used to, right? So you get angry quickly. You're much more agitated. You lash out at people. Is it any surprise, Mark, that if you come back from a mefloquine deployment with these symptoms, that you might erroneously, out of confusion, think that you're better off not being alive anymore?
This is exactly where I wanted to go.
Yeah.
So, is there any statistics that show specifically for victims of quinism, or people that show diagnosable quinism and suicide? What those rates are?
Well, I think it's much higher than any of us imagine. And unfortunately, Mark, in order to do a really good study of this nature, we would need the active cooperation and good faith involvement of militaries and veterans organizations. And as you can imagine, they are in they have no interest in collaborating or cooperating in work of this nature. Now we know anecdotally
and I'm going to add to that, when they do, it tends to be minimized.
That's right.
As an example, everybody talks about the 22 push-ups, the 22 veterans a day, where the real numbers at least double that. And the people that have studied it to any degree, they know that. So it's
Yeah.
not 22 a day. It's more like 50 a day
Yeah.
is a lot closer.
Yeah. In the U.S.
Um,
military, right? Yeah.
in Canada, there was a study that says, oh, the suicide rate within the veteran community, it's about the same as the general public, which was complete horseshit. That is not true at all.
Well, and of course,
Uh,
it shouldn't be anywhere close to that of the general population, because military service members are selected for their good health. And so if you are going to serve in the military, it means you generally don't have a pre-existing history of precisely those mental health conditions that would place you at significantly increased risk of suicide. So, for example, folks with schizophrenia and other psychotic disorders, folks with chronic depression, they're not eligible for military service because they're at much higher risk. Well, for many reasons,
I
but
will
because they're
disagree with you there. Based on U.S. military statistics, and the U.S. is really good at
yeah,
stats, Canadians aren't. But according to U.S. military stats, there is a very strong correlation between a high ACEs score, and for those that don't know, ACEs is adverse childhood
yeah,
events, so childhood trauma, and it's scored, and we'll call it on a scale of 1 to 10, 10 being extreme, 1 being none at all. And there's a direct correlation to the trauma-rich environment that's chosen as a career. This is also shown within first responders. But if, let's say, you join to go into the infantry, chances are most infanteers, if you look at their ACEs score, that they're going to have a score that's above the normal of 3, and it's going to be like a 6. And if they go airborne, it's probably a 7 or 8. If they go
hmm
tier 2 or tier 1 special forces, it's higher again, and they are able to see that very clearly within the U.S. So that's something to fold in, and the higher your ACEs score, the more your trauma cup is full. The more your trauma cup is full, the
yeah,
less room there is, the less capacity for going into an even more trauma-rich environment than your childhood was, which is a war zone.
yeah.
Which is why the propensity and the susceptibility of a post-traumatic stress injury is higher. It's because the ACEs score is higher.
Yeah, that's a fair point. Psychiatric epidemiology surrounding suicide this is a fairly robust literature, and we know there are distal and proximal risk factors for suicide, or distal and proximate risk factors for suicide, and you need generally to have both in order to have a suicide committed by a military member or a veteran. And some of what you talked about, the ACEs scores, those are distal risk factors. Proximate risk factors are things like stress, financial problems, your
Mm-hmm.
girlfriend leaving you, that sort of thing, the more immediate things. And absent a distal risk factor, you're able to move beyond whatever burden of proximate risk factors that you may be exposed to, but with a large and growing burden of distal risk factors, which include high ACE scores. But the predominant distal risk factor is a history of mental illness, of diagnosed mental illness. Most psychological or psychiatric autopsies is almost always some either diagnosed or undiagnosed mental illness in your background. And certainly a history of prior suicide attempt and a history of severe mental illness are by far the highest risk factors for suicide. And in the U.S. military, not to get off topic too much, but in the U.S. military, what we saw corresponding to a surge in suicides among the active duty population, this was attributed to many things like multiple deployments and so on, but it also correlated with the period where the U.S. military was simply throwing the rule book out, Mark, and admitting people who probably shouldn't have been let into the military at all. So folks with prior suicide attempt, severe mental illness in adolescence, we were just turning a blind eye to this very serious history of mental illness because the military was so desperate for manpower at the height of the Iraq and Afghanistan wars. And this is why militaries for decades have precluded one joining the military if they have a history of diagnosed mental illness or use of psychiatric medications, which indicates some sort of severe mental illness. There are many folks who have had adverse childhoods. As you note, I think this is a pretty common story in military populations, but absent a history of diagnosed mental illness or treatment for mental illness, often the military can help people move beyond that, and they can have a very successful military career and even thrive. And
Well,
now, of course,
there's another wrinkle to that as well. Part of having a high ACEs scores means that you've
mm,
overcome that. So
yeah,
if you're still alive and because you
yeah,
made it through that
yeah,
more than challenging childhood,
yeah,
uh, It is
Yeah, we
that
call that
level of
survival bias in epidemiology. So the fact that you're still around means that you've developed some sort of resilience.
which is why you're able to pass your battle school, which is
Yeah,
why you're able to get through buds.
yeah,
People that haven't had childhood adversity don't make it to the special forces. They just can't because it's the first time they've had real adversity.
yeah. That's a good point.
And this is the British military show this that
Mm,
nobody that gets to the infantry and actually passes, much less their special forces like a tier one unit like the SAS, they all have come from the rough streets. They all come from a
yeah,
rough background. Otherwise, they simply don't have the mental tenacity, the
yeah,
resilience to survive the training.
yeah. Well, that actually brings up another point that's worth emphasizing, and that is that what militaries have done in recent decades related to Mefloquine is they've tried to blame the effects of Mefloquine on precisely what you're describing. And so in the early years of Mefloquine's use, what the drug company did and what the U.S. military did and what militaries all over the world did was when a soldier came back from a Mefloquine deployment complaining of, I'm anxious, I'm depressed, I'm not sleeping right, what the doctors would typically do, what the drug companies would typically do, is they'd go digging. They would go digging for some evidence of pre-existing mental health problem. And as you're suggesting, perhaps not surprisingly, they can find almost always in military veterans, they can find something. Maybe the father didn't treat them right. Maybe they were, beat up as a child. Maybe if it's a woman veteran, maybe they were sexually assaulted, or even a man veteran, maybe they were sexually assaulted. They've had one or more of these adverse childhood experiences, or they've had episodes of depression or anxiety or drinking in the past. And the effects of Mefloquine for many decades were blamed almost exclusively on this pre-existing history. And so unfortunately what developed was this misunderstanding that if you take Mefloquine and you develop problems, that it's not the fault of the drug, it's your fault. It's that you have this latent mental health vulnerability. You have these latent mental health problems, and the Mefloquine isn't causing these problems. It's just merely re-exposing or reigniting a problem that you already had. And of course, this is 100% bunk. This is simply not true. You could give this drug to Mother Teresa. You could give this drug to the most well-adjusted person in the world with the most comfortable childhood, and they could still experience all of the awful effects that we've been describing. It's no different than blaming some inner city kid with lead poisoning, blaming the fact that they've lost IQ points and have become violent and their personalities changed, blaming it on their parents or blaming it on something that happened in their childhood. They've been poisoned. Their brain has been poisoned by a neurotoxicant, and whether it's lead, mercury, Mefloquine, the effects of neurotoxicants can affect any brain, no matter what the brain has seen in its life up until that point.
And usually for life. So let's talk about treatment. And
Yeah.
so diagnosis is a bugger, but you're confident that you can diagnose quinism
Yeah.
with a fairly high degree of certainty.
Yeah.
Where are we as far as treatability? Because right now, any of the people that I know that are suffering from quinism, man, they're all struggling. Like they're struggling bad, and they've had bits of hope with different therapies, but nothing that's really cleaned it up. So
okay.
So
I think we need to look at an analogous situation. So during the Vietnam War, beginning in the 60s, many Vietnam veterans would come back from war, and they would tell their doctor, something's not right. Something's wrong with me. And I don't know what it is, but I just don't feel right. I'm having all these awful symptoms. And the doctors would look in their diagnostic and statistical manual. By this point, it was DSM-3. Oh, no, it was DSM-2, pardon me. And they would say, well, there's nothing in here in my psychiatric manual that corresponds to your symptoms. So it's all in your head. You don't have anything. You don't have a psychiatric condition.
If it's not on the book, you must be nuts.
Well, yeah, and the doc, what's the psychiatrist going to say? You must be crazy because you have a psychiatric condition which isn't in my book. So
you know what else is all in my head? My brain.
Right.
Poke a couple holes in that. It's still all in my head.
So let me continue. So these veterans, not surprisingly, Mark, because they weren't afforded a correct diagnosis. Not surprisingly, there wasn't anything offered to them in the form of treatment. You can't investigate treatments. You can't submit a drug for approval to the FDA for treatment of a condition unless you first recognize the condition and you do studies of people with the condition to see if the drug works. So the example I was sharing with you was post-traumatic stress disorder, right? These veterans were coming back in the early to mid 60s, late 60s with post-traumatic stress disorder, but it wasn't yet in the book. It wasn't yet in the Diagnostic and Statistical Manual. And I believe it was only 1980 when DSM-3 was published that PTSD was formally recognized as a psychiatric diagnosis. Now, it took many years for many veterans to be formally diagnosed with that. But what was going on with them, Mark, before this? Probably nothing, right? They were probably self-medicating. They were going to the VFW and the American Legion Hall, and they were just having lots of drinks every night. They were self-medicating for their condition because the psychiatric community was completely disinterested and unable to help them, right? And so unfortunately, this is the situation that we find ourselves in with Mefloquine poisoning or Mefloquine encephalopathy or Quinism, as I call it. We can't expect the medical community to have done any sort of formal work towards investigating treatments in any real systematic way that we can say is evidence-based before they acknowledge the existence of the diagnosis, right? So any treatments that I, as someone who's familiar with this, individually as a clinician with some professional experience in this area, and any recommendations I might give in this regard are going to be completely anecdotal. They're not going to be based on any sort of systematic study as is ideal in medicine, and will be largely based on individual case reports. Now, what I can tell you is this: as far as setting realistic expectations, we know that veterans with, for example, traumatic brain injury generally suffer some degree of impairment and lowered quality of life indefinitely as a result of that. The brain does not have the same ability to heal itself as other organs. If only every organ was like the liver, where you can just have a little tiny bit of healthy liver tissue left and the whole thing will regenerate. Our brains are not starfish. They don't regenerate limbs. They don't regenerate tissue. So once the brain suffers an injury, I think we need to accept that almost certainly there's going to be a decrement in function and performance. And so much of helping Mefloquine veterans consists of setting realistic expectations and dealing with the grief that comes from recognizing that they've been poisoned. And very, very often, simply knowing that they're not crazy, that this is not all in their head, that they're not faking this, that they haven't gone nuts imagining these effects, that this is a real effect, that this is the result of a poisoning, and that other people have exactly the same symptoms. And so you could look at other people and say, this is not something that people are imagining. This is a real effect. This itself, Mark, I think can be very therapeutic to veterans because it allows them to begin the grieving process and eventually the healing process, the mental healing process. And I suppose understanding that you may never fully heal will allow you to make the changes in your life that lead to an improved quality of life. So I don't know how many times, Mark, I've heard people say, I'm going to go back to school.
As far as effective treatments, has there been anything?
Well, hold on. I'm getting to that. So I think what you're describing is a cure. There's no cure.
Just things that help, things that take the foot off.
Yeah.
The gas.
So let me continue. So an effective treatment, I think, would be managing expectations and not overstressing your brain. So in much the same way as folks with traumatic brain injury need a lot of sleep, right? They need a lot of rest. They shouldn't be overtaxing their brain. They shouldn't be participating in too many activities. They need to accept a lower level of function in their life. I think so too, folks with Mefloquine poisoning, I think they need to understand that they're not going to be performing at their maximum necessarily into the future. So I've had many veterans say, I'm going to try to get my life back together. I'm going to do this. I'm going to do that. I'm going to go to school. I'm going to write a book. I'm going to do all this stuff. And that now very, very often they will succeed to some degree, but often that's too much because cognitively you're not able to manage as much. You get fatigued much earlier. You have a lower threshold for getting frustrated and agitated, right? No different than someone with traumatic brain injury. So managing expectations and recognizing that you should have a lower level of expected performance, I think is part of treatment, right? I can't point to any specific science or studies, but based
Well,
on
I so strongly disagree with you. Like I understand what you're saying,
yeah,
but lowering the bar is not treatment. That's a coping mechanism, and coping
yeah,
and healing are not the same thing.
no,
So as far as something that actually, and you also said that neurogenesis doesn't happen, but we know it does happen. Neurogenesis has been proven through functional mushrooms, various functional mushrooms, as well as various psychedelics. The one right now that's been shown very well to have remarkable neurogenerative effects is ibogaine, and it's just become legal in Texas and is becoming legal in others as well. And the effects of it have just been spectacular. And if the neurogenesis caused by ibogaine and other psychedelics, although I think ibogaine is one of the most powerful and effective ones that I've seen so far.
mm,
Um, if it helps with neurogenesis, with that reverses or at least drastically improves all the other symptoms of other mechanisms of injury like CTE or PTS, post-traumatic stress injury, or concussion, et cetera, that all line up and can all be lumped in the basket called brain damage, which
mm-hmm.
mefloquine poisoning is. It's a form of brain damage.
Yeah, that's right.
So if it helps with these other forms of brain damage, why not mefloquine? And have you looked into ibogaine or any of the psychedelics as a potential treatment for there to be a little bit of hope?
Well, Mark, when you ask me, have I looked into it? What you're really asking me is, have I conceived of a well-powered, ethical, randomized control study where I would identify, let's say, 100 people without mefloquine poisoning. I'd identify 100 people with mefloquine poisoning, maybe 200 people with mefloquine poisoning, and then I'd divide those 200 into two groups, maybe three groups. One given a placebo, one given the drug that you mentioned. Possibly give the healthy people some of the same drug to see how it affects people who don't have the underlying condition. And then,
randomized placebo-controlled studies. I understand.
Right. So, Mark, if you have a couple of $1 million lying around, by all means, please share that with me, and we can consider getting that started. But
it's been done. That's what I'm telling you.
Among Mefloquine veterans is the question, right? So, in order, if someone were to let's imagine a future where step one, governments acknowledge that this condition exists, Mark. This is a prerequisite to any progress in this area, because so long as the government denies that this exists, clinicians that get paid by those government agencies are generally not going to be willing to diagnose this condition and recognize it in their patients. So assuming first that governments recognize that mefloquine poisoning is a thing, right? And that they commit to addressing this problem, not only paying appropriate disability compensation to the folks whose lives have been ruined by this and who haven't been adequately compensated for other misdiagnosed conditions, and then assuming that the government is then able to and willing to commit to funding the type of science necessary for this. In order for us to get to the point where a doctor can see a patient with mefloquine poisoning and say, oh, by the way, did you take mefloquine overseas? Oh, you did. Did you have nightmares while you were taking mefloquine? Oh, you did. Maybe you don't have PTSD. Maybe you have mefloquine poisoning. There's a new drug for this. Let me prescribe you this new drug. Let's see how it works. In order for us to get to that point, Mark, we need governments around the world to admit that they've been lying about this for decades and that mefloquine poisoning is actually a thing. Then they need to probably spend hundreds of millions, if not billions of dollars, correcting the disability gap in underpayments for this condition, right? Then they need to fund research studies. If PTSD and TBI are any guide, hundreds of millions of dollars that they would need to spend to fund all sorts of centers to investigate this. Maybe after 5 or 10 years of these studies, there may be a candidate drug that could go before the FDA, and they could do phase 1, phase 2, finally phase 3 studies where they give a placebo drug to some people with confirmed quinism, and they give this treatment drug to some people with confirmed quinism, and they follow them for 6 months, 12 months. They confirm its safety, and then they confirm its efficacy. At that point, maybe we could have something that we could call a treatment based on typical standards of medical evidence. But this
So
is a
the
very,
short
very,
answer
very
is
long way.
the shorter answer is no. There's
Be- be- so, so, so,
there's no
well,
right now
so, so, so,
there's nothing that can help.
so, Mark, look, there are many doctors out there that will sell you vitamins, and they'll sell you this pill or that pill, and they'll say this cures this, that, or the other thing. Right now, maybe it's because I come from an academic background, and maybe it's because I've been, so involved in drug regulatory issues. I appreciate how difficult it is to make credible statements, not only about the dangers of drugs. Right? Think how hard it's been for us to get drug regulators to even recognize the dangers of mefloquine. I recognize how difficult it is to gather sufficient evidence to be able to make credible claims of efficacy for particular conditions, right? Just because drug X might be effective for condition Y, and condition Y is very similar to condition Z, it doesn't mean that drug X is going to be effective for condition Z. There's any number of examples out there, Mark, of a drug that you might think would work for a closely related condition that doesn't, right? And what we don't want is we don't want to be in a situation where we engage in the same sort of sloppy review of drug X, thinking that it's going to be a miracle cure for Mefloquine poisoning, and that leads to even more problems, right?
I'm not talking. I've never suggested a numerical cure. I'm just talking about help, improvement, move the needle. That's all
Mark,
I'm asking about.
Mefloquine was sold to us as a very helpful drug that would stop soldiers from dying. Mefloquine was taken by soldiers because they thought it would keep them healthy. So you have to be very careful when you're saying that a particular drug is going to be helpful, because that's exactly how we got into this situation in the first place, isn't it?
But so anyway, at the end of the day, the answer is there's no recommended treatments. There's only management. No. There's only coping mechanisms, but there's no actual treatments that we know of for sure.
Yeah. Well, now here's where I can share some anecdotes for you, and it's often said that the plural of anecdote is not data, meaning you can't draw conclusions from multiple anecdotes. But I've heard a few of these stories, Mark, and it's enough to make me think. So there's a poor fellow who's in jail right now. He took Mefloquine not in the military. He took it for some sort of civilian trip, and he went from a perfectly well-adjusted, healthy college-age kid, I believe, to coming home completely wrecked, Mark, by this drug. It may have been 4 pills, 6 pills, just a small number of tablets. Came home completely psychotic, changed his life, and we're all familiar with stories like this from veterans and others. This poor fellow was laboring under what must be horrific hallucinations, thinking that there were monsters in the house, thinking that his family members were demonic. Who knows what was going on in his mind? But it was
crippling.
Yes, and clearly mentally ill, right? But no one recognized it as such, or at least recognized the potential. Apparently, I may be getting the details wrong, but apparently he set fire to the home, and maybe in the process killed or allowed his family to burn to death in this house. And not surprisingly, was sentenced to life in prison. I don't know if an insanity defense was attempted, but regardless, he's in prison. And over time, he's become aware of the effects of the drug on him, and I think he's come to some degree of peace, that it wasn't him. But in the process of trying to improve himself, he had gained some weight. I think he was a little bit unfit. So in the process of improving himself, he decided to go on a ketotic diet, the Atkins diet, where you cut out all carbohydrates from the body. And he also started working out. And he lost, I believe, a lot of body fat. And in the process of getting on the ketotic diet, what you do is you switch your brain from running on potentially inflammatory glucose to what we think is a soothing anti-inflammatory ketones. And this change, he reports, having been associated with a remarkable change in his mood. So he was less anxious. He was experiencing these intermittent psychotic breaks prior to this, where he would have these moments of aggression and anger and psychosis. And switching to a purely ketotic diet eliminated this. And
Well, it's not just the ketones on the keto diet or
no,
carnivore or whichever. Our brain runs on cholesterol. We
no,
need cholesterol. That's why
no.
vegetarians have actually smaller brains, like
Mm,
physically smaller, because they're just not getting cholesterol. So the ketosis, and this is one of the things that I've talked about on the show a
mm,
lot. If you are in a bad way with mental health, one of the most aggressive things that you can do is a 48-hour fast.
yeah,
The ketosis starts kicking in around 36 hours, and it is the quickest way to get out of that pit. And
yeah,
it's wonderful,
yeah,
but it's not just the ketosis and the ketones. It's also that you're feeding your brain with the cholesterol that it needs.
yeah.
One of the guests that I've had on a couple of times, I don't know if you've read the book, but Bonnie Kaplan is the co-author, professor emeritus, University of Calgary,
Mm,
and called "The Better Brain," and talking about micronutrients and how the brain is a hungry, hungry hippo,
yeah,
and how it's very underfed. So when you underfeed it, all the symptoms of depression, anxiety, um, go down the list, and they're all heightened.
yeah,
Add the add the correct nutrients, feed that hungry hippo, and all those symptoms abate significantly. Uh,
yeah.
Including resilience. So resilience and resistance to a post-traumatic stress injury have been shown, and there's well over 200 studies that she cites in the Better Brain book. Actually, I haven't talked to Bonnie in a while. I got to bring her back on the
Well,
show.
Mark, so I wouldn't disagree with anything you're saying, and unlike my advocating for use of a particular drug, which could be problematic, in general, there are few risks associated with someone taking part in minor dietary changes. I would still clarify for your listeners. Look, I'm not your doctor. I'm not giving medical advice, but in general, it's much safer for someone to change their diet, ideally with their doctor's permission and supervision, than it is to maybe try a new drug. And as you said, there does seem to be a growing amount of evidence that simple dietary changes can change the way your brain functions. And an anti-inflammatory, healthy lipid type environment for your brain, not just ketones, but as you said, maybe a healthier lipid profile and some other changes. This for whatever reason,
Dropping sugar, dropping drinking,
yeah,
because those are
absolutely,
incredibly
no doubt.
inflammatory,
Yeah, no
incredibly
doubt about that.
inflammatory. So
And
if what you're suffering from is neural inflammatory, well, then stop inflaming it.
yeah,
Douse the fire.
yeah.
Get rid of and for cancers as well. Quit dousing the fire.
No. Well, I'm not going to give anyone any advice on how to manage their cancer. You should talk to your oncologist about that. But in
Well,
general, our
inflammation doesn't help.
yeah, our diets are trash, right? Modern
Yeah.
Western diets are trash. All the stuff that's at the inside of the grocery store aisles, all that stuff is garbage. And if
Yeah.
people do, if people eat more just natural foods, healthy meats, eggs, low carbohydrates, low levels of processed food, low levels of seed oil, and they go back to a natural, healthy diet such as we evolved to eat. I think a lot of the problems of modern living would be eliminated. And you see this down in the States with the Maha movement and so forth. Even changing seed oils that we fry French fries in, replacing that with tallow. Huge difference. Uh,
Absolutely.
but now that being said, let me just complete this. So this individual reported not only a change in his mood, an improved change in his mood, but a reduction in
Mhm.
these events, these seizure-like events. And what this reminds me of, Mark, is the early treatment for pediatric epilepsy. So back in the old days, back in the 19th century, we had no fancy drugs, but kids were still born with seizure disorders. So how do we treat them? We had no idea until it was discovered that if you stick these young kids on a high fat, low carbohydrate diet, basically the equivalent of a Atkins diet, that their seizure activity decreased. So many kids, even to this day, are treated with an ultra low carbohydrate diet, and it for whatever reason, I suppose as you were mentioning, depending on what types of nutrients you substitute, maybe fish, beef, maybe some healthy lipids for some unhealthier ones. Maybe the improvement is greater. But regardless, if you just cut the carbohydrates and you substitute protein and fat, these kids, their seizures are almost entirely eliminated. And it may very well be that what's going on in some Mefloquine veterans is that they're simply having this intermittent underlying seizure activity as a result of brain inflammation, bad diet, and so on. And that by controlling your diet, by shifting into a high fat ketotic diet, you may be minimizing the propensity to have these effects. Again, not medical advice, talk to your doctor, but many people benefit from a carnivore, ketotic, Atkins-like diet anyway.
So I would call that a treatment. I think we differ on definitions.
Yeah.
So
maybe
that I would consider hopeful.
Yeah.
That's a beacon of hope, and it doesn't hurt you to try it.
Well,
so
it could.
For anybody that's suffering from quinism, I don't want them to listen to our conversation and go, well, fuck it. If there's no hope, I'll just eat a bullet. I don't want that. So
that's definitely a worse adverse effect than whatever might result from a ketotic diet.
Yeah.
But that being said, ketotic diets aren't for everyone. I think it's important that folks at least talk to their doctor and say, look, is there anything I should know about before starting this? I really want to start this. Talk to your doctor. Make sure it's safe
on
for
that, because I know you have to say that for insurance reasons.
Yes, I
know
do.
That.
Yeah,
but I don't. So talking to your doctor about a keto diet is, you have to say that, but is the worst advice that anybody could give, because
lots of doctors, Mark, that are supportive of these new diets. There are many doctors that see the benefits.
What, 5%?
Maybe more, but it's worth a discussion.
Okay, let's be generous. Let's say 15. Like it's fair not
enough. Fair enough. I think it is true. Some doctors will dissuade you from it.
Yeah. Let's even say 80%. When I was on the keto diet, I've been on carnivore with my wife for a while. And it's not all roses. We have to supplement. We have to have our electrolytes up. We have our potassium. I had a problem with low potassium. I didn't realize it as a direct result of the carnivore diet. So,
this is why I say see your doctor, because low potassium is potentially harmful.
Right. It's not a panacea. It's not a magic bullet, but it's certainly helpful. And the difference, like if I'm eating pizza, which I love, at least I used to, but if I'm munging down on pasta and pizza and other high carb inflammatory foods, man, I feel it. And especially now that I've detoxed from all that, and my wife's reporting the same, like you have a weekend of cheating because you're at the parents' place or you're on the road or whatever. Right. Holy smokes, do you ever feel it? It's and you can't wait to get back on a clean diet. Another way that
I know the feeling.
When I had Dr. Bonnie Kaplan on, she said, just stay out of the center of the grocery store. Stick to the edges. The edges is where you find the bakery and the deli, and just stay away from boxes and bags as much as you can. Because
there's more than a few ingredients on the box. It's probably not a healthy food. It's probably processed to some degree, and we definitely need to modify. So look, as bad as the problems are from Mefloquine poisoning, and obviously this is an area of great interest to me, because I've done most of my research in this area, and I've talked to lots of folks. Just from a public health perspective, the problems we're talking about, the problems caused by poor diet and so on in total affect many, many, many more veterans. Think about how many U.S. veterans, Canadian veterans, have problems with obesity and diabetes and early heart disease as a result of all the junk that they're eating, right? So as a public health problem, these problems with diet are as bad as Mefloquine is, obviously responsible for much more morbidity and mortality. But the problem with Mefloquine, it's so unjust, Mark, because it's so obvious to the veterans who are affected by this that this is a real problem, and it's been so obvious for so long. And
there was no opt-out. For the Canadian soldiers, especially in Afghanistan, there was no opt-out.
No.
You had to take it.
You ordered to take it, right?
in Somalia, there was an
Yeah,
opt out. I
yeah,
was in Croatia in '94, so right after Somalia, because I think Somalia was '93, if I got that right.
yeah.
But
92 to 93.
uh,
Yeah,
for whatever reason, even though we were not in a malaria area, I remember the medic offering
really.
Mefloquine, these little blue pills,
Yeah.
and like
No,
an
not blue
idiot,
pills. No, 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 no. Maybe
they weren't blue.
doxycycline, blue pills, daily pills.
Don't remember. It was a long time ago.
Yeah.
But whatever it was, I popped because they said, "Oh, we're using this in Somalia." I remember the conversation, but
Hmm.
you don't really need it, and it's for malaria. So I remember popping one, and then my buddy looking at me like, "Are you an idiot? You don't need to take it. Why take it?" I'm like,
Yeah.
"Oh yeah, that's right." So I threw the
Well,
rest in the
yeah,
garbage.
there was a lot of that. So I mentioned my service in Afghanistan. I'm a public health
Yeah,
doctor. You think I'd know better, but we deployed to Afghanistan in January of
yeah,
2007. We landed in Bagram. There was snow on the ground, and we started taking our Mefloquine right away. Why? Because according to our command, and I didn't oppose this as much as I should have. According to our command, it's just easier if we start taking it now, because then we don't have to figure out when the mosquitoes are coming out and when to start taking it. So our folks in Afghanistan were taking Mefloquine for 3 or 4 months when there weren't any mosquitoes because it was snowy.
and
And
it was
and
obligatory as well, right? Like you had
yeah,
to.
well, now some units, depending on the unit,
Okay,
there was more or less what's called directly observed therapy. So many units, and this all depends on the unit. Many units would just give you a box of Mefloquine and say, take one a week. Now, other units, and I think this probably would vary with whether they had malaria cases in the past. Because if a unit had several malaria cases, the commander would probably be told, look, you need to enforce Larian discipline or Mefloquine discipline. And the advantage of Mefloquine to military forces, because it's taken once a week, is if you are going to give it in directly observed therapy, you can just line up everyone in formation once a week and go around and stick a tablet in everyone's mouth and have them take it. So the once weekly dosing schedule of Mefloquine, it facilitates directly observed therapy, many of the worst cases of Mefloquine poisoning that I'm familiar with were associated with this directly observed therapy, meaning you had some poor soldier that was floridly hallucinating. They might have been hallucinating monsters and snakes and dragons in formation, right? They were being actively poisoned by the military. And instead of saying, hey, Sergeant, I'd rather not take this pill because I think I'm going crazy. What soldier is going to do that, right? It would
yeah, and
threaten their
everybody called
career.
it like if the
No,
pill was every Thursday, it was Nightmare Thursdays.
yeah, exactly. So unfortunately, the fundamental problem with Mefloquine is that you may be able to conceive of a situation where you could more safely give Mefloquine to a civilian traveler or a business traveler, someone going on vacation, but in the military context, it's almost impossible to give this drug safely. And the reason is that it says right on the drug label, Mark, if you're taking this drug and you develop any of these symptoms, you must immediately stop taking the medication. Anxiety, depression, restlessness, confusion. Okay, first of all, those symptoms are ubiquitous in military contexts anyway. And so even if it's very clear that you're having these symptoms because of the drug, other people, your doctor, your medic, your sergeant, are going to attribute those symptoms to something else. You're going to say, oh, I'm having a hard time sleeping, I'm having nightmares. Your sergeant is just going to say, well, you're just being, can I swear here on the show? you're
Absolutely.
you're being a pussy and just take your pill, right? Well, that wasn't
Yeah.
really swearing, but it might get you a strike on YouTube. uh, so the problem is in military settings, it's almost impossible to ascertain reliably the onset of these prodromal symptoms that require the immediate discontinuation of the drug, right? What service member is going to admit, hey, Sergeant, I think I'm going crazy. I'm seeing things, right? That's going to land you either in the brig or it's going to get you a Section 8. You're going to get discharged. So the military should have known that it couldn't use this drug safely, right? From the very first days when the drug regulators slapped these warnings on the drug saying, if you develop these symptoms, you must immediately stop. And early on, Mark, the military might have said, well, these symptoms happen so rarely that it's not that big of a deal. 1 in 1,000, 1 in 10,000 people might develop insomnia.
When you're
But by
heavily armed in a combat zone, waking hallucinations are
probably
probably
not
not
good.
good, especially
Probably
if
not
you're
good.
shooting at them.
Yeah. So now we can get into a discussion of the seemingly coincidental advantages of mefloquine side effects in military context. But let me just get back to what I was discussing. In 2001, Mark, all doubts were eliminated about how common these symptoms were. So in 2001, there was a study published that very clearly showed that 1 in 10 people taking mefloquine compared to another drug develop things like nightmares
Dear Lord.
or vivid dreams. So the military knew as early as 2001 that if you give mefloquine to, let's say, 100 people in a company, that at least 10 of them should be coming forward within the first few weeks saying, hey, doc, I'm having these crazy symptoms. I think I need to stop. So after 2001, if a military was giving out mefloquine to a unit and they weren't seeing 10, 20% of people reporting side effects, they're basically complicit in the harm that occurred because they should have known that this drug was causing these symptoms and that these symptoms necessitated the immediate discontinuation of the drug. Now, if 10, 20, 30% of people who take mefloquine are having these symptoms, hopefully, if they're not subject to directly observed therapy, most of them will just stop after the first or second dose that they take and they have these symptoms. But if you're under directly observed therapy, if you're ordered to keep taking this drug, I think that the rate of permanent adverse effects is going to be much higher in those units because instead of stopping the drug when you have the first indications of it poisoning your brain, you're sometimes forced to take 2, 3, 4, 8, 16, depending on how long the deployment is, additional doses. And all of that additional mefloquine has been demonstrated to be a neurotoxicant in your case, to be acting on your brain, is building up in your brain and probably causing more severe side effects. So the whole, the whole rationale for using this drug in military contexts and the very strange justifications militaries had to make to justify the continued use of the drug. Basically, the military had to say that all the warnings on the drug label were just a bunch of bunk, right? In order for militaries to justify giving out this drug, they basically had to ignore all the warnings on the
That's
drug
a pretty
label.
good segue right there. So let's go back to what you said step one was. Step one is the government's admitting that there's a problem. Now,
Yeah.
I thought that there was some progress in Canada, at least, that they said, yeah, that's Mefloquine poisoning is a thing. So they have gotten to step one. Is that true? And
No.
also, where's the state? So Canada hasn't admitted it.
Well, so I think every military that's used mefloquine will now freely admit that its continued use is much less desirable because of an unacceptably high level of acute adverse effects. So I think the Canadian military, the US military, French, German militaries, they'll all admit that this drug really isn't suitable for military use only because a large proportion of people that take the drug experience these undesirable side effects, anxiety, depression, restlessness, confusion. And maybe they've even accepted that because this requires the immediate discontinuation of the drug, even for logistical reasons, it doesn't make much sense to give mefloquine out. Because look, if you're sending a company of troops overseas all on mefloquine, you have to anticipate switching 10, 20, 30% of them to a different anti-malarial at some point. And if they're in the middle of operations, if they're shooting at the bad guys, and the bad guys are shooting back at them, it doesn't make a whole lot of sense to deal with the medical requirements of switching anti-malarials. So just simply from an operational perspective, I think most countries realize that doxycycline or atovaquone proguanil are much more advantageous and superior at anti-malarial. And you won't see any militaries really giving out much mefloquine now. Regardless.
From the perspective of Veterans Affairs, though, is the injury acknowledged and is it being compensated for?
So now, I believe what Veterans Affairs Canada would say is they would say, well, look, for argument's sake, let's suppose that mefloquine causes all these symptoms that resemble post-traumatic stress disorder or traumatic brain injury. Just for argument's sake, let's suppose that this drug causes those effects. I think what Veterans Affairs Canada would do is point to every single veteran who is claiming that they were injured by Mefloquine. And they would go through their files and they would say, well, look, this veteran is already being compensated for PTSD. This veteran here is being compensated for PTSD and TBI. This veteran here has 100% rating for PTSD and anxiety. Veterans Affairs Canada would probably say, look, any veteran that might claim that they're disabled or injured by Mefloquine, we're already adequately compensating them for other conditions just as well as we would be compensating them, even if we admitted that Mefloquine poisoning was a thing. That's probably Veterans Affairs Canada's position on this.
I think you're probably right.
Yeah, and that is an interesting. So it's an interesting legal question whether that is actually a valid defense. So I would argue, and we'll see if this comes to pass in the legal proceedings that are
well, it's
underway.
the same challenge between a post-traumatic stress injury and TBI, because they line up on the DSM as well, which is concussion, which is post-traumatic stress injury.
And of course, if you're fully if you're 100% compensated, then what difference does it make what we call it, right? So for
access to treatment is the difference.
Well, that's exactly that's it.
That's the difference. I mean, financially there is no difference. I agree, but access to treatment is a pretty big deal. I am pretty sure that I'm suffering from a TBI, but guess what my benefits are through post-traumatic stress injury. But it's a similar issue to Quinism. Getting a proper diagnosis, and it's an uphill battle.
Yeah. So I can tell you how things are done in the States. It's a little different in the United States because unlike Canada, I think you have a single office that adjudicates disability claims in Canada. I think it's in PEI, if I'm not mistaken. And so I think it would be very easy to ensure a certain way of doing things is enforced at that one location. But in the United States, veterans' disability claims are adjudicated in a decentralized fashion. Many dozens of centers, I think, around the country adjudicate claims.
It's partially state-run, isn't it?
No, so the process of helping veterans, the process of helping veterans advocate for their claims and assisting veterans in filing their claims, very often you'll have state and county, local governments hire people to help submit their claims to the federal VA. But the VA claims are adjudicated federally, but they're adjudicated in a decentralized manner. And although the federal VA could, in theory, issue guidance on how to manage Mefloquine-related claims, I think for whatever reason they haven't wanted to put any formal guidance in writing so as not to set any sort of precedent and not to create a situation that might be subject to criticism or challenge. So there's been nothing stopping individual veteran claimants from presenting their case and having individual VA adjudicators weigh the evidence and award claims. So in the States, we've probably had hundreds. I'm familiar with many, many dozen. I think it's well over 100 now. I'd have to count. But let's say there's probably been several hundred U.S. veterans who took Mefloquine who've been successful in having one disability or another formally attributed to their use of Mefloquine. So for example, if I'm able to talk to the veteran before they file their claim, I may tell them, look, if you are claiming that you have a mental disorder, anxiety, let's say, due to Mefloquine, you probably don't want to claim post-traumatic stress disorder because everything's just going to get attributed to post-traumatic stress disorder. If instead you want your condition attributed to Mefloquine, you have to file for something unrelated to trauma, right? Because anxiety disorders, we don't think they develop in response to things. They just spontaneously develop. So if someone develops a non-specific anxiety disorder or depressive disorder, then it's possible for us to argue, look, the etiology of this is not a true psychiatric anxiety disorder. This is anxiety symptoms that meets the psychiatric definition of an unspecified anxiety disorder that's actually the result of Mefloquine exposure. And this is a convoluted argument, but many times the VA will acknowledge this reasoning. They will say, look, the veteran was completely healthy. They took Mefloquine. Even before they deployed, they started having anxious symptoms. Sometimes that's documented in the medical records. And then they deployed. It wasn't terribly stressful. No doctor thought they met criteria for post-traumatic stress disorder. They come home. They still have anxiety disorder. What's the cause, right? It's Mefloquine. And so there have been many claims of this nature, sufficient enough to establish that this is not rare. This is the fact that there have been hundreds of these cases.
But but as you said before, even though it seems clear, and you would say it's clear, benefits have still not been provided on the basis of, okay, that's Mefloquine poisoning. Here's your benefits. Here's some compensation. That's still not happening.
Oh no, they have. So in the United States, there are probably hundreds of veterans who, if you look at their paperwork from the VA, it says anxiety disorder awarded at, let's say, 50% due to Mefloquine poisoning. There are many, many examples of this in the United States where the etiology of the disability has been explicitly attributed to Mefloquine. Now, in some of the cases, they don't include that in the rating decision. They don't include that in the paperwork. But there have been cases before the Court of Veterans Appeals, before the Board of Veterans Appeals, where the judge specifically notes the causal role of Mefloquine. Now, in the U.S. military, it's a little
different. I misunderstood you earlier then, because it sounded like you were saying that there, what I thought I was asking earlier about this, I thought the answer was no, it's not being recognized. So it is, but it isn't.
Well,
at the end of the day, some people are getting compensated.
So here's
it's acknowledged that it's Mefloquine.
So here's the rub. No one at any sort of central high up level will, in the U.S. so far, will acknowledge that this is a thing, right? So you won't have anyone. You won't have anyone in the high levels of the Department of Veterans Affairs. You won't have anyone at high levels of the Department of Defense say, yes, there are hundreds of these cases where veterans have been awarded permanent disability.
They don't want to open the floodgates.
Yeah, exactly.
It's just
right?
all liability. Yeah.
Well, but this is not, Mark. This is nothing unusual about this. This is par for the course. We've seen this movie many times.
Agent Orange, man.
Exactly. And think how long it took. Think how long it took.
On our tour, we were something similar to Agent Orange happened to us on our tour. In digging in, filling sandbags with heavily contaminated bauxite that was polluted by PCBs.
Okay.
And but no, nothing to see here.
Right. Yeah, this is par for the course. So what the VA will do is they feel they have a fiduciary responsibility to the taxpayers, and so there's an expression down here. I don't know if it's the same up there. Delay, deny, wait till they die. Right. This is what the VA is accused of doing all the time. Look, I have every confidence that in due course, once we get to the point where we have several hundred of these Mefloquine veterans with paperwork saying, I'm disabled due to Mefloquine, and we get them all in an auditorium, we get them all in a conference room at the U.S. Capitol, and there are hearings there, right? And we fill the room with them, and then we have a day of witnesses where they all testify to having been affected by Mefloquine. I have no doubt at that point we'll be well on our way to getting official acknowledgement. But it takes time, right? These individual cases, sometimes I work with these veterans for a couple of years just to get a single case awarded disability benefits. This is a long, hard slog.
The discontinuity is mind-blowing. I mean, you're getting awards, so veterans are getting awards for it, and it's saying on their paperwork, that's what it was. It was Mefloquine, and yet the top. Oh no, nothing to see here.
Well, but according to the VA, it doesn't set a precedent. So according to the VA, a single case doesn't set a precedent, and the VA's official position would be, well, those claims are just wrong, because claims are awarded incorrectly all the time, Mark. They are. I mean, there's all sorts of mistakes made. So they would call these false positives, right? But I have no doubt that eventually we will get to the point where, and I think it may be the U.S. military that acknowledges this first, and it probably should be, and I'll tell you why, because I'll give you the politics behind this. So Mefloquine wouldn't exist if it weren't for the U.S. military, right? Roche, that developed Lariam under its brand name, would never have brought this drug to market if they weren't under some pressure from the U.S. military. So it's understood that this drug became available all around the world and was adopted by other militaries at the behest of the U.S. military. Now, for the time being, the U.S. military still runs the show. And I think out of courtesy, I think our allies, Canada, England, so on, they don't want to come out and basically throw the U.S. military under the bus by saying, oh yeah, this drug that our friends in the United States that we rely upon for all of our arms sales, they developed this awful drug and poisoned our people. I don't think the British government is all that eager to acknowledge that formally. I don't think the Canadian government, I don't think Mark Carney wants to have a press conference where he says, yeah, the United States is terrible. Well, actually, maybe now with the politics as they are, maybe this is the time for
No.
Canada to finally
I
say,
mentioned Agent Orange earlier,
yeah,
which was affected us as well. Agent Orange was used
right,
in the training area on the East Coast,
yeah,
and a lot of Canadians poisoned and cancer and are dead because of Agent Orange.
yeah.
Still not acknowledged.
Yeah, and the Canadian government's basically just doing the United States' bidding by denying this.
Yeah,
But perhaps relations will deteriorate between the United States and Canada in the near future sufficiently that Canada might actually say, we're tired of lying and covering this up, on behalf of the United States. Here's the truth that we've known about forever, that this drug is a poison, and you've been poisoning our people ever since '92 when we took part in the Somalia campaign at your behest. If there was someone honest in the Canadian government, they would say this, right? And there are folks in the Canadian government that know this. They've known this all along, but it's been the longstanding policy of the Canadian government and VAC and Department of National Defense to basically lie about this because
lay
you're dealing
down
with,
until they
well, but there are these international political considerations, right? Because this is an American drug that was developed by the U.S. military for U.S. military purposes. And I'm assuming that, as bad as relations may occasionally be between the allied countries, no country wants to throw the United States under the bus by singling out this drug. But eventually it'll happen. And I think eventually the U.S. military will admit the problems with this drug. And then you'll see every country very quickly acknowledge the dangers. Now this could be forced out of them, Mark, right? This could be forced out of various countries through legal settlements. So in the UK, for example, you may be familiar, there was a longstanding court case. I think it was going on 7 or 8 years, and I was involved in this as an expert witness, writing reports behind the scenes. And I can't share too many details, but my impression was, had it gone to trial, the UK government would have stood a significant risk of being very embarrassed, because I don't think their experts were really all that prepared for the favorable testimony that our side would have provided. But that being said, a decision to settle as opposed to going to trial and letting all your dirty laundry out, the decision to settle is one that you have to respect the judgment of the attorneys, because they're the ones paying the bills and everything. And the law firm that was involved in representing several hundred or several thousand UK service member plaintiffs, they made the very difficult decision last year, I believe, to settle these cases before they went to trial. And I think the amount that they were awarded was a pittance. It was maybe 20 million pounds, which apparently is what the government was spending on legal fees every year, right? So, but it was at least a token acknowledgement that the plaintiffs had a case, and I think they just wanted to expeditiously deal with it. So, unfortunately, many UK veterans, I've been told, it's not even enough to pay for their funeral.
As Veterans Affairs go, UK between Canada, the US, and the UK is a distant third. The way that they treat their veterans and their access to help, access to resources, it's the shits. It's really not good.
Yeah, it almost seems like you have to
is.
sue every time for benefits. It really is an odd situation. It sort of reminds me of the situation before workers' compensation, right? Before workers' compensation schemes were implemented in our countries in the progressive era, the 20s and so on. If you were injured at work, you'd have to sue your employer and go to court and maybe get some compensation that way. And I think in Ireland and I think in the UK, it's still a legal antagonistic process. And of course, in Canada and the United States, fortunately, we have an administrative system where you're entitled to benefits so long as you meet certain minimum criteria. You generally don't have to go to court. It's much better. Generous in Canada, much more generous in the United States. The bar in the United States is very, very low.
One of the guys that I had on here, his fight with workers' comp was brutal. And it was actually only because of him being on my show. And by the end of it, they listened to the episode. So they were able to get the full story in full context. And they went, oh. we misunderstood, and he got his claim as
Yeah.
a direct result of joining me for an episode. So
Yeah, and I'm sure I'm sure the media attention and so on also aided it. Yeah, so in the UK, the issue's quietly gone away, but I think the tacit understanding by all parties is that the veterans did have a point. The plaintiffs did have a point. Mefloquine did cause permanent harm in many cases. You're probably not going to see much out of the UK immediately, but because of this settlement, the UK is going to be in a much better position, I think, to acknowledge these problems in due course when they get the signal from the US. Now in Canada, the court cases are still playing out. I think there's well over 1,000, maybe several thousand, I'm not sure, individual plaintiffs who are suing the Canadian government. But my understanding is that maybe one of the biggest problems that the Canadian plaintiffs face is precisely this, that they're potentially barred by legislation from suing for damages if they're already obtaining full benefits for other things. Now, from a medical perspective, there are very strong arguments as to how this is inadequate. This is clearly inadequate because the full scope of their disability is not being acknowledged, and to the extent that
there's been dozens of court cases of Canadian veterans versus the government over the last 20 years.
Yeah, for insufficient compensation.
Happening.
Yeah.
Oh yeah, and there's active numerous active court cases happening right now. And I don't know if the clip was as viral in the States as it is up here, but in Canada, everybody knows the clip where when we had Trudeau as a prime minister, but when he was our PM and he's doing a town hall in Edmonton, a buddy
Dave
of mine,
Bona. Dave Bona.
Well, Dave may have been there, but Brock Blazchek stood up and asked Prime Minister Trudeau, "Hey, why are you fighting all the veterans in court?" Now, to put it in perspective, Brock Blazchek lost one leg in Afghanistan. The other leg is totally mangled, but still working. So here's a guy with a missing leg from Afghanistan. And so why are you fighting us all in court? And Trudeau said, "Well, the veterans are just asking for more than we can give right now." He says this to a guy who gave his leg.
Yeah, well, that's generally
and
unwise.
all the people that gave their life.
Yeah, that's so. The tacit understanding, the whole reason we have veterans benefits, is so that in the future, when there is a situation where your country needs its young men to agree to go to war and potentially pay the ultimate price, they will understand that the country has their back if they come home injured. So Trudeau may not be much of a student of history. I understand he was a teacher. But he probably didn't study much history, because everyone will tell you that studied history, that counsels, figures of government, you want to ensure that you don't say anything stupid that might dissuade future generations from being willing to go to war and fight and die. And of course, saying something like that is a surefire way to not have eager recruits in the future.
No, it's not a great recruitment poster by any means.
It's not. Yeah. Well. So, and ultimately, this is what will, I think, decide this issue, right? The reason the United States has awarded all of these benefits for Agent Orange and TBI and PTSD is the understanding that if we don't take care of our veterans for all of the numerous problems that result from military service, then why would future generations agree to fight? So thus far, the Mefloquine issue hasn't yet captured the public's attention the way these other issues have. And to the degree that we take part in advocacy in our nonprofit organization, the Quinism Foundation, to the degree we take part in advocacy, we're very aware that as bad as this problem is for us and for the veterans that we represent, there are so many other worthy causes, right? For many years, the Agent Orange veterans have been fighting to have their compensation properly granted. The Blue Water veterans, the naval veterans who were exposed to Agent Orange, they've waited patiently. Gulf War still is not fully addressed. And these folks are all in line ahead of us, right? These folks are all in line ahead of us. And these problems have mostly been resolved. There are a few outstanding problems. I think the Gulf War issue needs to get fully resolved. But at some point, Mark, what I expect is all of the other worthy groups who have legitimate grievances with the VA and the government, who need to have their particular problems acknowledged, all of these problems will be taken care of. And then it will be our turn. It will be the turn for Mefloquine veterans. Now, I know there's probably a Mefloquine veteran listening to this saying, Dr. Nevin, what's taken so long? It's been 40 years. Yes, that's about how long it takes. It takes about 40 to 50 years. That's how long it takes. Think about Agent Orange was used in the 60s, and the VA up until just recently was still fighting those claims. Gulf War illness took place in the early 90s, and we're still fighting. It's been 35 years. So we're getting to the time now where the Mefloquine issue is really quite ripe. It's ripe for a change. All the people in the militaries who were responsible for this, who issued the drug, who recommended it, they've all retired. They've all gone into nursing homes. They're not going to be offended if we blame them now. Many of them have passed away. There's no one around in any of these organizations who are responsible for what happened, right? And
right.
bureaucracies.
And I agree with your logic. The challenge is that bureaucracies
they defend themselves.
They defend themselves.
They defend themselves, and they defend their leaders, right? Bureaucracies survive by CYA, right? Doubling down and covering the leaders and their decisions. In the same way that Trudeau should be giving veterans their benefits so that future generations of young men join the military, bureaucracies do the same thing, right? They respect your service by not throwing you under the bus, even if you've done something terrible. But we've got to the point where there's no one left to blame. They've all gone away. And
but
so
they protect themselves anyway.
Well, there's much less of a cost, I think. It would be much less costly for the U.S. military to say, I don't know anything about this drug. Apparently we used this many years ago, but we've just found out this is a really bad drug, and we admit it. People before us made mistakes. We're going to commit to fixing it. It would be a lot easier for someone with 2 or 3 stars on their shoulder to stand up behind a podium and say that now. It would have been much more difficult for someone to have said that 10, 20 years ago. So I do think we're close.
You got to wait for people to retire, and that's for sure. That's the 40-year mark.
Well, there's a saying that science advances one retirement at a time, and you would think that science advances based on presentation of new evidence and people with old ideas acknowledging that they were wrong. Let's get real. That's not how it works. And veterans policy, compensation, military policy, these things advance one retirement, one funeral at a time. And as the old guard moves on and, young generation steps up, assumes positions of responsibility, you're going to get folks in senior positions in the VA and the DOD and at Department of National Defense and Veterans Affairs Canada. You're going to get folks assigned to these positions who took Mefloquine and who know that it has these awful effects. And so they're not going to be as predisposed to opposing these changes. So I'm very confident we're very close, actually, to some major breakthroughs.
We'll keep our fingers crossed, and we're about there. So, Dr. Nevin, for you to do speaking gigs and to fund the Quinism Foundation, or I'd imagine you're taking donations?
Well, we do. So I generally advise folks against donating to us directly for various legal reasons, because we're not registered to solicit in many U.S. jurisdictions. But folks can donate to a donor-advised fund, which is a nonprofit, and request that they consider donating to us as a result. That tends to get around the problems with charitable solicitation. So you can find a link on our website, quinism.org, to learn more about that process. We do have a meeting coming up. It may be a little late, depending on when you air this podcast, but 2 weeks from now, I believe it's Monday, October 27th, if I got the date correctly, starting at 9 a.m. near the Detroit airport at the Detroit Hilton Garden Inn. We have our one-day annual educational meeting. The ticket's still available. Rooms at the hotel should still be available. So if anyone wants to make last-minute plans to fly into Detroit, you can hop a shuttle right from the airport to the hotel and join us for a day of meetings.
Is that posted on quinism.org? I think that's
you can learn more about that at our website, quinism.org. Just read the most recent newsletter and you'll get all the details about how to register for that conference and all the logistic specifics. But even if you can't make it to our meeting at the end of October, You can go to our website and read press releases and newsletters and learn more about this condition. Sign up for our newsletter and be informed of new developments. And of course, I'm happy to answer general questions. I can't offer medical advice to folks that email me with specific questions about their own personal condition. But if you ask me general questions about the condition, I can send you literature. I can give you my opinions on things and hopefully help you out that way. And for U.S. veterans and Canadian veterans that have individual disability cases where Mefloquine may play a role, we do offer a service where we offer a medical chart review and can comment on the likely causal role of Mefloquine in any case.
Alrighty. Thank you so much for spending the time with me today. I'm really happy about this conversation. I'm very satisfied with it. I think that we painted a vivid picture of what Quinism is and the state of it is from political and practical and from every angle that I could think of. So thank you for this deep dive on it. I think there's been a lot of value here, and anybody that's trying to learn about Quinism, I think they can really get everything that they need just out of this conversation alone.
Yeah, that's great. It's been a pleasure speaking with you, Mark.
All righty, please stay on the line. You're listening to Operation Tango Romeo, the Trauma Recovery Podcast. If you found value in today's episode, I'm going to ask you what everybody asks you, but it's for a reason. I'm going to ask you to like, comment, share, subscribe, because when you do that, it helps to boost this channel. And by boosting this channel, you're going to be a beacon of hope. I get notes all the time that listening to the show is the only resource that somebody has, or that it's a valuable resource that has saved lives because it gives hope and tools and access to resources. Sometimes that's all you need. So if you would like to help save a life, share like the sugar bear, because sharing is caring.